Thanks, Chad. Our next speaker from WashU is Puja Kachroo. She's going to speak to us about elective aortic arch repair.
Hi, good afternoon, everyone, and thank you for this opportunity. And I don't have any disclosures for this talk. I was asked to speak about, quote, elective aortic arch repair, and really, we're going to go through why, it's not really elective at all, and probably a lot of these cases we don't even want to do, but we have to. But I want to start with a little story first. So as it's been mentioned before that Dr. David has been, very instrumental in young faculties. And so I was giving, luckily, the plenary talk at the AATS during COVID, so I got to do it over Zoom. And Dr. David had to discuss my paper, and so he politely called me up and probably didn't agree with my results, but he basically explained the valve-sparing operation to me over the phone, took all my notes and kept them with me. Then I had this opportunity in Bogota in 2022, and I was supposed to first assist him, and I was so excited and honored. And he took the time before that time also to ask me about my career, and he mentioned Dr. Azunian and said she's going to be great, and now she's the secretary of the AATS. So I'm here, I'm excited. The Colombian surgeons are cannulating the patient, and so I come in to first assist him, and he's set the sutures for the subannular sutures for the valve sparing. And so all the snaps are going across the patient, and they're coming towards me. He's like, no, you don't need to touch them. So he snaps them to the drape. So then it comes around his side, so I'm like, perfect, this is my opportunity to go ahead and help him. So I put on my hand, and he just leans over the table and uses his belly to retract with his snaps. So I don't even think I touched the patient, but still an honor. And thank you very much for teaching all of that. So I wanted to start with a little bit of the guidelines, and I think there's a little room for improvement here of what we really consider to be class 1 indications. A lot of us know that we don't really operate much for symptomatic unless they're ruptured or acute dissection patients. But asymptomatic, what's really low risk in these patients? And, are we only operating for if it's 5.5 and now with connective tissue? And sort of there's been a surgical creep of, we operate on smaller and smaller aneurysms because they look big, or maybe the BSA. The other thing is if they're high risk, really the guidelines mention hybrid or endo and really don't really refer to open. And I think there's room for improvement in terms of we have to be careful of the anatomy of a lot of these arch aneurysms. So I'm going to present 5 cases, all varying types. So this first one is a 77-year-old gentleman with an enlarging aortic arch. So as you can see from his history, he was already pretty sick. He had gotten a carotid subclavian bypass. He got a TVAR back in 2020. And then they noted on follow-up that he had an endoleak, so they got proximal extension the following year. And then he developed a type B dissection, so they did a distal extension. And during that time of his TVAR for the distal extension, he suffered a stroke and had AKI. And so now this patient comes to me, and basically what you're going to be looking at is a type 1A endoleak as well as a type 3 endoleak. So a really large, now sicker patient, and really probably didn't have the anatomy to begin with to do endovascular repair. So in this case, I cannulate the innominate artery generally for ACP. The carotid artery is also clamped, watching cerebral nears on both sides. Generally for elective arch operations, cool to 24 degrees Celsius. And here I'm just sort of taking out the uncovered portion of the stent graft just so I can resect as much aorta and to oppose the aorta closer to the dacron, or the covered portion. So I was able to trim it. I put a wire here. I've sort of gone away from using the wire. This is the Thoraflex device. And basically this is just, I'm not going to show everyone how to sew circles, but essentially just sort of the setup and to keep it clean and keep it easy for yourself. You want someone to keep pushing down because you don't want the stent to come up and come out of the aneurysm. I take all of those branches and I clamp them off to the side. I like this operation from the left side of the table. It's always where I stand for the resident. And then basically just go around and secure with a felt strip. And then we can go over all of these just to make sure I actually do these. So zone 2 Thoraflex, and we've got a decent repair. I scan all of these patients, usually within the first or second postoperative day, depending on their kidney function, to make sure I actually did the operation well, and there is no room to do anything else. And another thing we all learned from Dr. David is really what's your experience, and to follow your own results. So I do all of the Thoraflexes at WashU, so I followed all the 47 patients I've done since the FDA approved this device back in October. Most of them were done for some form of dissection, about 15% for acute dissection. I do these in reoperation. Mean time for circ arrest is about 45 minutes. And most of them went on to some sort of completion TEVAR procedure for their residual pathology since I've been doing them. My operative mortality, 4 out of those 47 patients, 3 were mostly for ruptured dissections, and I did have 1 patient with a stroke and 1 with permanent dialysis. So again, know your experience. Since I follow all these patients, I saw this. Post-op scan was fine. This was a type A dissection for rupture. There was a separate tear in the arch. I did an ascending and a total arch replacement for this 78-year-old female. On the immediate scan in the hospital, it was fine, but on the month follow-up scan, you can see that there is some thrombus at the distal end of the stent graft. And so it's important to follow these patients, and here I started the patient on anticoagulation, and I referred them for a further TEVAR extension. Third type case is a 70-year-old female, pretty sickly lady. Back in 2018, she got a TEVAR for some PAU in her descending aorta. Again, not sure about the anatomy because they reported a, quote, mild residual leak. She had COPD and all the slew of problems that you don't want to operate on. So here she comes to me, and just to show that, this one's really just limited to the proximal. I wasn't worried about any other type of endoleaks. And here, just to show that I don't always use a Thoraflex every time when I do arches, and this is just from 2 days ago. Basically, we're cutting out this very diseased, heavily calcified arch, and I wasn't able to point it out here, but really the apposition was where the subclavian artery would have come in. And so that anterior aspect of the arch is really hard for some of these devices to maneuver around. And so you could think of repairing them with several sutures. I wanted a more definitive repair. I thought about cutting back even further, but here I thought, why not just do an end-to-end anastomosis zone 2 repair, and turned out that seemed to exclude the aneurysm sac, and this was her yesterday's scan, so she's doing well here. Fourth case, 54-year-old female. She presented with chest pain, bacteremia. She's had a slew of multiple infections in the past, every risk factor known to man, IV drug abuse, and she was homeless. She comes in, and she has this focal outpouching of her aortic arch that was less than 2 centimeters distal to the subclavian artery, a lot of enlarged mediastinal lymph nodes. In this case, really not excited about going into a ruptured arch situation, especially down the descending. So we elected to temporize her with TEVAR and try antibiotics for 6 weeks. But obviously, after 6 weeks, we got a PET scan. It still showed some FDV-avid aorta surrounding that TEVAR. Some people may opt to leave this alone, especially in higher-risk patients, and continue with suppressive antibiotics long-term. But in a patient, you're worried about their social status and not being able to be compliant with medications. We elected to take her for this operation, really tough spot to get to. But here we did it through a hemiclamshell incision. This is I'm helping one of my junior partners who just started. And basically, it's a very straightforward operation. You do a sternotomy, either whatever interspace you need to get into. This one, we use 4th interspace. We put a camera in so everyone in the room could see what was going on. We had groin cannulation available. So this view is a little difficult, but you can sort of look at the root vent and the ascending aorta. There's 2 clamps. I cannulated the innominate artery. There's a clamp on the innominate artery and the carotid artery. I did circ arrest for the proximal aorta. I did not perfuse retrograde through the groin at this case, since we're circ arrested. But essentially, we just took out the stent graft. This way, the visualization is actually really good in this hemiclamshell. So if that's an operation you might want to do if you're addressing the distal arch, proximal descending, even down to distal descending aorta gives you really great exposure. So the stent will come out. And I'm just going to play this video for a little bit just because I want to show exactly where the graft goes. It's, if you're looking on the right side of that picture, you'll see the lung is dropped. The pleura is kind of hanging on the right side where the phrenic runs. So we dump this graft into the left pleural space and essentially just sew our proximal anastomosis. We'll kind of get it in there, get that started. And here, now you want to start thinking about when you're going to do your distal anastomosis, you're going to want to have I've already had the groin open and cannulated, or ready to cannulate. And so at that point, after I finish this, I'm going to cannulate the groin and release this patient from circ arrest, take off the proximal clamps, let the heart beat, and then put a clamp on the descending aorta, in which, hopefully we're going to speed this along, but we'll put a clamp on the descending aorta. You'll retract the lung over. We're finishing up this proximal. I nerve hook all these sutures. It was something I learned during fellowship, and I think it's saved me a lot of repair sutures. But essentially, after completing this, you'll have an assistant sort of retract the lung over to the left chest, so you can see that's being sort of held away. And then you have a really great view of the descending aorta. I won't go through the distal, but essentially cut that out. You need to probably open the aorta up, intersew the intercostal vessels, and complete this. And fifth and final case is a patient with Marfan syndrome. He's had multiple operations. He had Marfan syndrome, mechanical Bentel in the past. He got a island technique reimplantation where you just reimplant all of the head vessels to the aortic arch back in 2002. He then subsequently got a thoracoabdominal. But in 2020, developed mitral disease, as a lot of them do, and ended up getting a mitral repair, a redo root replacement for a pseudoaneurysm. And the note by the surgeon, very experienced surgeon, said extensive adhesions making visualization of the arch impossible. And here she shows up in my office in 2024 with an enlarged aortic arch, about 6.5 centimeters, that grew about 2 centimeters in 4 years. So here I thought maybe I should take a very different approach. And so in this case, you can see the arch aneurysm that's just bulbous sitting at the top. And while I'm an experienced arch surgeon, I definitely was very cautious about going in there having a backup plan. And so what I started was I had a carotid subclavian bypass placed by our vascular colleagues, and I cannulated the left carotid, and I went on bypass. And then I sewed a graft onto the proximal aorta, created a Y graft, and then sewed it to the right common carotid and the right subclavian artery. And I weaned off bypass there, and then that way I was able to perfuse the right side of the brain, and then use that graft from the left carotid, and then reimplanted proximally, and then the patient got a stage TVAR, but I didn't get control of the base of the carotid artery or the subclavian because I just couldn't reach it and I didn't want to cause more problems with the patient. So one of our vascular surgery colleagues went during their stenting, also embolized both the base. And we actually got a very good result in this case. And to conclude, so really the indications for our surgery, I think, are still evolving because we really don't know the risk for all these various types of patients who show up. And I think the critical thing is to start with the anatomic suitability and see if that they're used, can we do this for lesser invasive procedures? And really, I think you still have to worry about cannulation. You still have to worry about cerebral protection, as well as how much are you really going to take out. And I think the most important thing is you got to know the unique complications that are associated with each of these types of repairs, and most importantly, your own limitations and results. Thank you very much for this honor.